we are going to start gallbladder. Before starting gallbladder, you should be knowing some basic anatomy of GIT. So suppose this is any GI organ and I'm going to take cut section. If I'm going to take cut section, you must be knowing that there are 4 layers in GIT. What's the innermost layer? That is known as mucosa. After mucosa, there is submucosa. After submucosa, there is muscularis propria. And after muscularis propria, there is serosa. You must be knowing in mucosa there are further 3 layers. Innermost is epithelium. After that, there is lamina propria. After that, there is muscularis mucosa. There are further 2 layers in muscularis propria. Inner circular and outer longitudinal. Inner circular and outer longitudinal. You must be knowing that there are 2 kinds of plexus in GIT. One is Auerbach plexus and one is Meissner's plexus. What's the function of Auerbach plexus? The function is this, what? Peristalsis. If the function is peristalsis, what should be the location? The location of Auerbach plexus is between inner circular layer and outer longitudinal layer. Auerbach plexus is located between inner circular layer and outer longitudinal layer. After that, Meissner's plexus. What's the function of Meissner's plexus? Yes, this kind of motility, and this is known as what? Villous motility. Then intestinal secretion. So if the function of Meissner's plexus is villous motility and intestinal secretion, the location should be in the submucosa. So this is the location of Meissner's plexus. So you can see this Meissner's plexus is located between muscularis mucosa and inner circular layer, or it is located in submucosa. This is the basic framework. Now lots of questions are asked about this basic framework anatomy. First question, in which particular organ there is no serosa, there is no villi, no secretions and no Meissner's plexus? That is esophagus. So in esophagus, no serosa, no villi, no secretions, no Meissner's plexus. But there is unique feature of esophagus. What? There is lymphatics in lamina propria. Be careful, lymphovascular supply is present in submucosa, but in esophagus, lymphatics are present in lamina propria. Second, what is the strongest layer of GIT? The strongest layer of GIT is submucosa. It is so strong that even we can prepare sutures from submucosa. Which suture? Catgut. Be careful, catgut is not the catgut. It is submucosa of sheep gut, prepared from submucosa of sheep gut. Which gut part? Specially ileum. So catgut is a suture prepared from submucosa of sheep's ileum. So submucosa is strongest layer. Second question, which 2 layers are missing in gallbladder? In gallbladder, 2 consecutive layers are missing, and those layers are muscularis mucosa and submucosa. So muscularis mucosa and submucosa, these 2 layers are missing from gallbladder. 2 questions are there. One, which GI organ is having maximum absorptive capacity and which organ is having maximum absorptive capacity per unit surface area? So have a look. Jejunum. is having maximum absorptive capacity. But maximum absorptive capacity per unit surface area is seen in gallbladder. Maximum absorptive capacity per unit surface area in gallbladder. Since it is having maximum absorptive capacity per unit surface area, it is going to concentrate bile. How many times can you see? 5 to 10 times. 5 to 10 times it is going to concentrate bile. So see the questions of anatomy and physiology about gallbladder. Gallbladder is pyriform in shape. Color is sea green. So sea green in color. Capacity 30 to 50 ml. Lined by tall columnar epithelium. Function is storage, concentration, and acidification of bile. Question is asked how many times it concentrates bile. It concentrates bile 5 to 10 times. These are the questions of anatomy and physiology of gallbladder. Now have a look of this organ. This is gallbladder. Now can you see this is cystic duct? In cystic duct there is spiral mucosal fold, and this spiral mucosal fold in cystic duct is known as spiral valve of Heister. Be careful, this spiral valve of Heister is not present in gallbladder. It's present in cystic duct. Very close to spiral valve of Heister, there is one sphincter, ill-defined sphincter present near spiral valve of Heister. This is known as sphincter of Lutkans. Known as sphincter of Lutkans. Now can you see this is fundus, this is body, and this is neck of gallbladder. Fundus, body, neck. There are certain glands exclusively present in the neck. What's the name? This is tubuloalveolar gland. Tubuloalveolar gland is exclusively present in the neck. It secretes what? Mucus. So these tubuloalveolar glands present exclusively in the neck secretes mucus. Now have a look of this simple diagram. Suppose there is a large stone impacted at cystic duct CBD junction. What will happen? Gallbladder will be massively distended with mucus, and this is known as what? Mucocele. So when gallbladder is massively distended with mucus, this is known as mucocele. So this is simple anatomy and physiology of gallbladder. Now going to start very important topic, and that's gallstones. So have a look. Most common type of gallstone is cholesterol. So first of all, we are going to discuss cholesterol gallstone. You must be knowing what's the composition of bile. 85 to 95% is water. In 5 to 10%, there is cholesterol, there is bile acid and lecithin. So one simple question is there. This cholesterol is water soluble or fat soluble? Fat soluble. So how it is made water soluble? With the help of bile acid and lecithin. And there is formation of what? Micelle. Because of formation of micelle, cholesterol is made water soluble. Now one simple question is there. Whenever concentration of cholesterol is going to increase, our bile acid and lecithin concentration is going to decrease. This bile is known as stone forming bile. This is known as stone forming bile or lithogenic bile. Now see, for formation of cholesterol gallstone, there are three mandatory factors. What are those? First, lithogenic bile. Second, nucleation. And third, stasis. When all these factors are present, there is formation of cholesterol gallstone. One by one, we are going to discuss. First, lithogenic bile. It is caused by supersaturation of cholesterol. What are the factors which causes supersaturation of cholesterol? First, obesity, high fat intake or high cholesterol intake, and clofibrate therapy. Why clofibrate therapy? Because after intake of clofibrate, there is secretion of cholesterol in bile. So there is supersaturation of cholesterol. Second factor is bile acid deficiency. Now have a look of normal physiology. You must be knowing that this is ileocecal valve and this is ileum, terminal ileum. There are two unique functions of terminal ileum. What? B12 absorption and second, enterohepatic circulation of bile salt. So any condition in which this terminal ileum is diseased or resected, in all these cases there is no enterohepatic circulation of bile salt, and because of this what will happen? Bile salt or bile acid is excreted in stool, leading to bile acid deficiency. So what? Ileal resection. Ileal disease. You must be knowing, in patients of obstructive jaundice, there is pruritus. To relieve pruritus, sometimes we are giving bile acid sequestrants, which are going to bind with bile acid sequestrants, which are going to bind with bile acid, and it is excreted in stool. What are those sequestrants? Cholestyramine and cholestyramine. So it is cholestyramine and cholestyramine which increases the risk of bile acid deficiency, which further increases the risk of cholesterol gallstone. Another factor is CYP7A1 mutation. It leads to bile acid deficiency. Third is lecithin deficiency. In which case there is lecithin deficiency, MDR3 gene mutation. In MDR3 gene mutation, there is lecithin deficiency. So these are the factors which are responsible for lithogenic bile. What is the second mandatory factor? That is nucleation. Now see, what is the nucleation? In nucleation, there is joining or agglomeration of microscopic crystal, and these microscopic crystals are going to join, form macroscopic crystal. So there are certain factors which promote nucleation. What are those factors which promote nucleation? First, infection, and second, mucin glycoproteins. So infection and mucin glycoproteins, these are going to promote nucleation, which is responsible for stone formation. After that, what is the third mandatory factor? And that is stasis. The third mandatory factor is stasis. What are the factors which promote stasis? Now let's see the factors promoting stasis. First, prolonged fasting. Second, prolonged TPN requirement. TPN means total parenteral nutrition. Third, pregnancy. Fourth, octreotide intake. Fifth, OCPs, oral contraceptive pills. And sixth, massive burns. Now see, what is the pathophysiology? It's very simple. See, whenever we take food, and if fat is there in the food, when this fat reaches duodenum, there is release of one hormone, cholecystokinin. This cholecystokinin is going to contract the gallbladder and bile is going to eject from gallbladder. If patient is not taking anything orally, there is no stimulus to release cholecystokinin. So in cases of prolonged fasting, there is stasis. In total parenteral nutrition, what patient is not taking anything orally, but it is patient is taking via parenteral route. Again, what happens? No stimulus, so no release of cholecystokinin. In pregnancy and OCP intake, most of the muscles are in relaxed state, so that also promotes stasis. You must be knowing somatostatin is universal switch off. The better analog and long-acting analog of somatostatin is octreotide. So if octreotide intake is there, what will happen? It will switch off the secretion of cholecystokinin, and what will happen? Again there is stasis. Similar situation occurs in massive burns. In that also stasis is going to occur. All these factors are responsible for cholesterol gallstone. Now have a look of pigmented gallstones. Pigmented gallstones are of two types. One, black, and second is brown. Black stones are insoluble bilirubin pigment polymer of calcium phosphate and calcium bicarbonate. Calcium phosphate and calcium bicarbonate. So one question was asked from this statement. What was that question? Which gallstone shows the property of polymerization? Can you see black stones? They are having property of polymerization. Second question. Any stone which contains calcium phosphate and calcium bicarbonate, tell me, the stone should be soft or hard? It should be radiolucent or radio-opaque. So you can see that since there is calcium phosphate, calcium bicarbonate, stone is hard. So these black stones are hard and radio-opaque. You must be knowing it is generally seen in cases of chronic hemolytic conditions. So, what are those chronic hemolytic conditions? First, hereditary spherocytosis. Sickle cell anemia, beta thalassemia, use of prosthetic heart valves, and Gilbert syndrome. Clear? Hereditary spherocytosis, sickle cell anemia, beta thalassemia, prosthetic heart valves, Gilbert syndrome. All these are going to increase the risk of black stone. Brown stones are composed of calcium bilirubinate, calcium palmitate, and calcium stearate. Brown stones are composed of calcium bilirubinate, calcium palmitate, calcium stearate. Be careful, this stone is more common in CBD, common bile duct. It is rare in gallbladder. It's rare in gallbladder. It is more common in developing countries. Why developing countries? Because of increased risk of worm infestation. So question, which worms? Ascaris and Clonorchis sinensis. So because of worm infestation, Ascaris and Clonorchis sinensis, there is increased risk. So see the pathophysiology, how it is going to increase the risk of brown stone. Very simple question. Have a look. This is liver. This is gallbladder. This is bile duct and this is duodenum. Suppose accidentally worm reaches the duodenum. This worm enters either into pancreatic duct or in bile duct. When it enters into bile duct, what happens? If it enters into bile duct, there is spasm of ampulla of Vater and the worm is trapped inside. After that, what? The worm is going to die and the dead products are going to collect. Now see what will happen? Dead products in CBD. Because of this, there is infection. By which organism? I told you, by E. coli and Klebsiella. If there is infection by E. coli Klebsiella, it is going to produce one enzyme, and that is beta glucuronidase. This beta glucuronidase is going to convert conjugated bilirubin into unconjugated. Conjugated bilirubin into unconjugated bilirubin. And you must be knowing that conjugated bilirubin is water soluble. Unconjugated bilirubin is water insoluble. And this unconjugated bilirubin is going to deposit and this leads to formation of brown stone. So this leads to formation of brown stone. So this is the pathophysiology of brown stone. Be careful. It's more common in bile duct. It's rare in gallbladder. And it is more commonly seen in developing countries. So questions are asked. What's the most common type of gallstone? Worldwide, most common type of gallstone is cholesterol. In bracket, mixed if given in the option. Be careful. If mixed is given, you will choose mixed. If it's not given, then only you will choose cholesterol. Now see what is the meaning. Usually, 95% component will be cholesterol itself, but 2 to 3% component might be black, 2 to 3% component might be brown. Actually speaking, the stone is mixed. If not given in the option, you will choose cholesterol. Next question. Most common type of gallstone in Asia, and that is pigmented. Here, what is the meaning of pigmented? Be careful, it's the combined incidence. It's the combined incidence of black and brown. Not individually black, not individually brown. So be careful. Most common type of gallstone in Asia is pigmented, and that's combined incidence of black and brown. These are the questions related to gallstone. Now have a look. Sometimes gallstones are having triradiate fissure. Can you see? Triradiate fissure. If plain X-ray is performed on plain X-ray, this is known as Mercedes-Benz sign. Mercedes-Benz sign. And sometimes in gallstone there is biradiate fissure. If there is biradiate fissure, this is known as seagull sign. So presence of biradiate fissure is seagull sign, triradiate fissure is Mercedes-Benz sign. After that, simple question. What's the investigation of choice for diagnosis of gallstone? So see, investigation of choice for diagnosis of gallstone: acute cholecystitis, acute acalculous cholecystitis, chronic cholecystitis. In all these cases, investigation is same, and that's ultrasound. I'm repeating. Investigation of choice for diagnosis of gallstones, acute cholecystitis, acute acalculous cholecystitis, and chronic cholecystitis is ultrasound. Next question. Gold standard investigation for diagnosis of acute cholecystitis, and that is HIDA scan. Nowadays, lots and lots of questions are being asked about HIDA scan. This is gold standard investigation for diagnosis of acute cholecystitis, having very high sensitivity and specificity. So can you see what's the full form? Hepatobiliary immuno diacetic acid scan. Hepatobiliary immuno diacetic acid scan. Now see how it's performed. See, the radionuclide agent is given IV. After that, it has been taken by reticuloendothelial cells. After that, it is secreted into bile. When we are going to scan this hepatobiliary pancreatic tract, we are going to see that in which areas there is uptake of this radionuclide agent and there is flow. Now can you see? Have a look. Suppose this is liver. This is gallbladder. This is bile duct. Now can you see on this HIDA scan what will happen? First there is uptake in the liver. After uptake in the liver, there is flow into bile duct. It goes into gallbladder also, and then it goes into small bowel, that's duodenum. If I'm going to perform HIDA scan, what's the picture? The picture of HIDA scan will be something like this. Can you see? So this will be the picture of HIDA scan. So you can easily make out what that there is liver, there is gallbladder, there is bile duct, and it is going where? Into small bowel or duodenum. Now imagine the picture is something like this. So this is the picture. What? You can't see the gallbladder. You can see liver, you can see bile duct, duodenum, but not the gallbladder. This is diagnostic of acute cholecystitis. Why? Because the initiating event of acute cholecystitis is temporary cystic duct obstruction. So because of this temporary cystic duct obstruction, what happens? There is non-visualization of gallbladder. And this question was asked many times. What is that diagnostic criteria of acute cholecystitis on HIDA scan? It's the non-visualization of gallbladder. What are the indications of prophylactic cholecystectomy? First, heart transplant recipient. Second, lung transplant recipient. So you must be thinking that what's the relation of heart transplant recipient and lung transplant recipient with gallstone? See, in these cases, cyclosporin is given, and this cyclosporin increases the risk of gallstone. That's why, to prevent increased occurrence of gallstone in gallbladder, we are going to remove gallbladder prophylactically. Third, prolonged TPN requirement. You know, TPN is a risk factor for gallstone. Fourth, bilio-pancreatic diversion. And you must be knowing that it's a type of bariatric surgery. Fifth, non-functioning gallbladder. Sixth, trauma to gallbladder. Seventh, chronic typhoid carrier. Eighth, gallstone more than equal to 3 cm in bracket more than 2.5 cm. Both of these were asked in exam. Ninth, adenomatous polyp. With stone. 10th, chronic hemolytic conditions. Chronic hemolytic conditions. 11th, incidentally detected gallstone. Incidentally detected gallstone during elective surgery. 12th, porcelain gallbladder. And 13th, gallstone in the relative of carcinoma gallbladder patient. Gallstone in the relative of carcinoma gallbladder patient. So can you see, these are the 13 indications of prophylactic cholecystectomy. Apart from this, there are no indications. So these are indications of prophylactic cholecystectomy.